like we've been labeled as low-cost models. So institution is a very comprehensive word for a lot of things, a hospital, a training, teaching, research. But I mean, obviously we are either looking into a practice, hospital, maybe a chain of hospitals, and these are other parts which can be integrated into an institution, into a hospital, which would be a part of the hospital. Like you train your own staff, train your own doctors, but if you are being a teaching institute, that is a costly proposition, because cost, everything costs and that matters, so we need to focus on that. Essentially, we first need to understand why. Why is what we are doing, whether it's a practice or whatever, why are we doing it? I think essentially most of us would be looking at this curve of scalability, of growth, propagation, and eventually in the last session I was the inheritance or perpetuity. So even after an individual, an organization, or an institution continues. So how do we begin? I think there are two ways. If you are a little altruist about it, it could be sacrifice, but then your followers you expect priests to follow, which is a difficult proposition. You don't get priests very often. But if you are taking risks, then it is a realistic proposition, it is a strategic proposition, and there you would be other people, other affiliations also taking risks. Now, grossly I'll come to that slide where you see the vast majority of India can barely afford private care. So for that welfare, where welfare is another wing, and the other group is aspirations. Now, that is the people who can afford to pay. Now, in this system, you can actually break it up into whether you want to give a very personalized, individualized, customized care, which is an art, or whether you have to give a generalized good quality care, which can be held with such systems and processes. So the second thing is, low cost is low quality. This is a very common perception, but people who have traveled, and most of you must have because it covers 53% of our airline, so you must have traveled Indigo. So they, I think, break this perception of being low cost. There'll be 500 rupee less, at least the next airline, but they're top quality. It is not like, Simply Fly, where people used to, I'm not naming the company, but would try to take away the tag, because that really appeared cheap. So there's a difference between being cheap and being cost effective, because when the entire organization focus on cost, then there is an efficiency around cost, there is a transparency around cost, there's a purpose around cost. So I would say cost is the first step to quality, because if people around you cannot afford, it doesn't exist. So quality, again, when you get the numbers, they do like Srinivas told, it does magic to your it does magic to your quality. And there are frills. In every technology, there are frills. So as technocrats, we must be efficient enough to see the frills out and focus on the technology where anybody almost can do it for everybody. And suppose you give a 300 rupee Optos, and probably that patient had a 2,000 rupee experience somewhere. I mean, this fair price creates an immediate faith. I mean, this institution is superb here. So you get more following, more economies of scale. And economies of scale, perhaps, is the greatest churner of everything. The compliance and the follow-ups and the people coming in to the brand, this is the biggest thing. So, of course, there are lean and clean things, like a very transparent financial system. I think from day one, you must have this, and also record every transaction and every MRD. I mean, that must be this, and go ad hoc, step by step, brick by brick. Now, infrastructure, if you're not very sure, you can go by rent or even revenue sharing. By revenue sharing, I mean the promoter might want to be to a part of your business. So you say, okay, you give me the place, I'll give you 7% of the top line. So these kind of revenue sharings can also occur. And please see that, it's expandable. The upper floor is available, something like that, visible, because you don't need eye care every day, but people should see whenever that should be, in their memory. And anytime they have a problem, they can well come there. And it should be accessible closer to the bus stand, railway station, something like that. And equipments can to reduce initial capex, you can put it on hire, which you all know. And sleeping costs, this is the main thing. And this is where economies of scale and early startups help you. And say in a bigger organization, sleeping costs can be minimized. Like in Aravind Eye Care System, I have seen, the entire crowd follows from the registration, then to the consultants, then to the optical store or to the investigation, but they come at the same time. But if they come over the day, it can be disbursed. But it's a culture of an organization. So, and staff multitasking. Like we encourage multitasking in our staff by saying that, see, if you teach your job to the other guy, because we say that if you are wanting a leave, then please say who's going to work for you, an unplanned leave. So that is how multitasking really helps. If the front desk can actually go to the OT and assist, there's nothing like it. So, and of course, the other cost optimizations like doctors on a salary with incentives, and then brands get more because, when people become 45 and they have a name for themselves, that is when they try to leave the organization. So if you pay them more than the newcomers for every surgery, probably they'll stay back because we don't give ESOPs. The people who's on stage who consider ESOPs. And and everybody tries to justify their remuneration. And the one message that can well be given that, be on the patient side. Don't try to, work for the hospital or see how much revenue you can bring to the hospital. It will automatically follow. Another thing about low cost is that, it is very surprising that in some hospitals I find the price tags so high that I don't know how the employees actually treat their parents or their family, because at least that must be an objective. If I've created an institution, my staff can at least treat themselves with respect. And of course, everybody is speaking about these things. So essentially, we must understand that good things are yet a lot to come. And we have 20 years and 20 very vital years. And if we can really hit the block, we can really take a flight. But let's see how we go. And so, India has everything. It has a Singapore with the population, with the GDP. It has a Poland. It has a Mexico. It has a Philippines. It has a Pakistan. And it has an entire sub-Saharan Africa. This is what I was talking about, that these people probably don't have anything but to do but welfare. And if you compare it with the lens consumptions from the industry, it actually substantiates what the startups have worked up. The upper one is something that I'm giving you from a startup group study. So this is the difference. Like you see how different Delhi is from Maharashtra and from West Bengal and to the base or even Bihar. So please adjust yourself to the low economy of the geography that you are in over the next 4 or 5 days. Now again, it's very interesting to compare what would the average ticket size of cataract surgery be. Like it would be about 1.5 times. Now what actually is the difference of the per capita per month? We worked it up with even Arvind Eye Care System. Now, obviously, you may find your one to be higher, but this is where you need to respect. And so this is the story that I was saying, Srinivas was saying. But if you have 500 patients in the OP, you definitely get 10% myopia, so 50 per day. So that's 300 rupees and 38 lakhs a year. So in 2 years, your recovery is done. The rest of it is surplus. We have 7 installations of them because 7 of our hospitals see more than 500 patients a day. So we have these wonderful theaters again, and it works in the same economies of scale. And it costs us 1,000 rupee per surgery because you do 2,500 surgeries a year. And to do 2,500 surgeries, you need to see 25,000 patients a year, or maybe even more. 7% is the surgical intervention ratio. Now about the scaling up area, there's some fundamental formulas for a average economy and a low risk model. So don't start a surgery center if you are below 30 and your practice isn't growing that much. So, these are the various steps of growth. From here, you can choose to divert it to 50 patients. You can have a second hospital. I just have 2 slides. Is it okay? So, again, OPD, remember, is an area where you actually do a lot of cross-subsidization. And, but they are the first barrier to entry, so you might consider cross-subsidization. Financials should be clear to you. So you can have a click because I can't explain you this slide. And see, OCT, you can give it at 300 rupees. We give it at 300 rupees because all our centers see more than 100 patients a day. So, please follow this number, the 10. So for every 10 patients, there is 1 OCT. And when you give it at 300 rupees, the doctors are probably more inclined to see the macula optically, by optical coherence rather than by a 90D. So, ठीक है, इसका phobia dull है. Let us have an OCT. So, and again, IPD costs, don't be tempted, as technocrats, to have a surgery center quickly. Until you are seeing, the cost of surgery, you probably easily get, even in the bigger cities, you get a center, surgery center for 6,000 to 8,000 rupees, all inclusive. But that works for that center, but won't work for you unless you do 100 patients a day. So again, at the end of it, through internal accruals, I asked, we had some money, so we are starting this hospital very close by, 600 bedded. It's a big project. If you have time, please go and visit that. We'll be very happy. It's under construction. We should be done by the end of this year. Thank you for your attention. Thank you.
Thank you, sir. That was a wonderful talk. Any questions? Quickly, please. Sir, if no question, I have a question for you. Sir, when you were speaking about the economies of the scale, now we are seeing that, of course, Disha has grown into multiple horizontal branches, and now we are speaking of economies of scope, and now we see that the multi-speciality hospital is also coming up.
Yeah.
So it's just for all the LDPNs here, it's just like Amazon, how it started with a bookstore, and now you see whatever is possible is available in the Amazon. So it's
Yeah,
just
yeah,
like that.
there were a lot of backward integrations. Like a certain number of patients can justify a spectacle shop within your practice premises. If you grow further, you can probably include a pharmacy. Still bigger, even at our scale or at I Foundation or at ASG scales, they can definitely support an intraocular lens company. So these are backward integration of things which can carry forward. And obviously the multi-speciality was a kind of a dream because everybody, including our patients, they said, they miss this low cost, fair priced quality area in multi-speciality. So
Because
the staff also
what
wanted
I
it, the doctors also wanted it, and
Would you
the
be
patients
able to,
also wanted it.
would you
So-
be able to do it in the multi-speciality? Here you are appointing your own doctors. Multi-speciality, you will have to bring in doctors. They would want a different arrangement because you're already spoiled by that, no?
I'm boiling my head on this here. We'll
But the HR
work a way out.
But the one thing we need to remember, the HR most commonly remains the same. So the most of the staffs who are working
See,
there,
multi-speciality is also multi-choice.
yeah.
I mean, we did not go into the details, but grossly speaking, what we are focused on, nursing, the intensive care, and the neonatal and pediatric care. So that team we are recruiting, that we can bear. The rest of it is visiting. So the patients will come and they will pay for their doctors.
I think we'll take more questions. Parth, last question.
Yeah, sir, it was a wonderful presentation. I have just one question. Like, as you have already told, like, if you have 30 patients, if you have 50 patients or 100 patients, different pricing. Like a new person who has just started the practice, he's not having that much of the patient flow. He's increasing the price. His experience is less, his prices are higher. So how he will stand in the market against you?
See, you have time. A doctor who has less patient has time. So give time. Your patients will be more impressed till you hit the figure of 30. See, Rome was not built in a day. Everybody has something in excess of the other. Our doctors are not as personal as you think they are. You are.
Yes, very true, sir. But just
So-
one thing, like what we have started in the Gujarat.
No,
like
this
we
I
have-
said, see, this 30 startup for a surgery center is for an average economy where, the per capita is moving around, say, 30,000 a month, something like that. But in Delhi, 5 patients, 8 patients are good enough because they pay twice, thrice as much. Yeah.
Very true, sir. But just one thing, like what we have started in Gujarat, we have started capping some of the prices. So even trust hospitals or some private hospitals, they can't go below that prices. So at least newcomers who are just coming to the practice, they can also survive and they can also be in the game.
See, you cannot expect that, somebody will, it's not undercutting. It's like, you've seen there are 50% of the Indian population cannot afford any practice.
Yeah.
So, if you criticize Disha in that point of view, I would say, no, I'm saying, it is an allegation to us that we probably undercut. See, you are instilling inspiration into a big subset of the population who actually would never come under the private eye care space.
Yes.
So that is the major point rather than you feeling the competition. Now you feeling the competition wherever you are, you feel the competition in the city. Go to the next town that is not there. You can spend 2 hours on travel.
So I think Dr. Debasish needs a big clap for the very wonderful achievement he has done in his lifetime.
Thank you, Debasish sir, for this wonderful